Ladies and gentlemen, dear colleagues, welcome to this e-seminar organized by the European Renal Nutrition Working Group of ERA. And of course, this working group is encouraging the research and the impact of the lifestyle, diet, nutrient homeostasis, and protein energy wasting management in chronic kidney disease, the outcomes. Today, we have an important topic that is incremental dialysis. And by participating live, the attendees will earn one European credit for their continuous medical education. But I would like to underline that this is an exclusive benefit for ERA members. Discussing the approach to the diet is not a novel situation in chronic kidney disease, because we are very well aware of the importance of the diet in the conservative treatment of the disease. And we have also, we know that it's important to start peritoneal dialysis in an incremental way together with the nutritional approach. More recently is the topic related to the incremental hemodialysis, again, considering the Dietary approach. So for discussing these important topics, we have two speakers. One is Massimo Torreggiani from Le Mans, France. The other one is Carlo Garofalo from Naples. And we have two eminent panelists, very expert on the field, Philippe Chauveau and Karine, that is, I think that we'll discuss, we challenge eventually the presentation of the speakers. But I would like to underline that the participation of the attendees with the question and answers is of paramount importance for having a very lively discussion. So without any hesitation, I think we can start asking Massimo Torreggiani to give the presentation about the incremental hemodialysis together with the diet. Please, Massimo.
Thank you for the invitation. It's a privilege and an honor to be here with you today. And I will focus on incremental hemodialysis. So this is my disclosure of interest. I have none. And so this is the outline of my presentation. I will start from guidelines to see what they tell us. Then I will briefly show the problem. I will introduce the previous experiences about combining diet with dialysis, and then I will talk about our experience here in Le Mans. So what do guidelines tell us? For dialysis patients, we all know that the protein intake should be around 1.2 grams of proteins per kilogram of body weight per day, whether they are diabetic or not. And the caloric intake should be between 25 and 35 kilocalories per kilogram of body weight per day. When it comes to patients on chronic kidney disease not on dialysis, the energy intake does not change. It is always between 25 and 35 kilocalories per kilogram per day. But the situation is the opposite for the protein intake, because in order to reduce the progression and the symptoms of CKD, patients should be under a low protein diet or a very low protein diet with an average protein intake between 0.3 and 0.4 grams per kilogram per day, supplemented with keto analogs. And this is true for patients with chronic kidney disease from stage 3 and on. So if we imagine the situation of chronic kidney disease as a black hole, we can imagine that the CKD is what is around hemodialysis, and incremental hemodialysis stands at the event horizon. So it's at the frontier between the transition between CKD and hemodialysis. But why to apply a low protein diet in chronic kidney disease? To reduce the nitrogen intake, to reduce the glomerular hyperfiltration, to reduce phosphorus intake, to reduce metabolic acidosis, and hopefully to preserve residual kidney function for longer in order to reduce CKD symptoms and progression. But what is incremental hemodialysis? Well, the definition has a little changed over the years, and for us, as we published, is every dialysis schedule other than the classic thrice weekly dialysis one. So it means once weekly or twice weekly. What are the benefits and the cons of an incremental approach? Well, the incremental approach reduces the dialysis shock at the transition between the ambulatory phase and the dialysis. It is patient-friendly. It allows the correction of advanced CKD complications when medical therapy is not enough. It allows fine extracellular volume tuning in cardiorenal syndrome patients, and it reduces treatment iatrogenicity. Among the contra, there is the risk of underdialysis, a need for more frequent monitoring of the patient in terms of blood tests, and if the patient has not a sufficient residual kidney function, the need for ultrafiltration could be high, and there would be a risk of residual kidney function loss. And on the other side, the incremental approach does not significantly reduce the need for medical therapy. So in 2014, Kalantarzadeh listed 10 characteristics the ideal patient should have to be put on incremental dialysis. Among them, a good residual kidney function, a limited fluid retention between two consecutive hemodialysis sessions, a limited and readily manageable cardiovascular or pulmonary symptoms without clinically significant fluid overload, a suitable body size relative to residual kidney function, hyperkalemia and hyperphosphatemia should be infrequent or at least readily manageable, a good nutritional status, lack of profound anemia, infrequent hospitalization, so a low comorbidity, let's say, and a satisfactory health-related quality of life. This is speaking about a twice-weekly schedule. But the first approaches to combine dialysis with an incremental schedule of hemodialysis were undertaken in the 80s, in particular in 1981 by the group of Mitch, who took 7 patients on once-weekly hemodialysis and performed a study divided in 2 protocol phases. The first one with, let's say, a normal protein intake of about 1 gram of proteins per kilogram per day, and the second phase in which the protein intake was reduced to 0.4 gram per kilogram per day, supplemented with essential amino acids. What was the rationale behind this approach was to reduce the nitrogen intake in order to balance the nitrogen waste product generation, and so have reduced the need of depuration by dialysis. And as we can see, the approach was quite successful because it was able to halve the urea generation in between the dialysis sessions. So this was the first experience that proved to be at least safe for the patients, give some clinical benefits, controlling the nitrogen waste product generation, but it was reserved to highly motivated and selected patients. In 1987, the PISA group studied the same thing on once-weekly dialysis combined with diet in 17 patients and compared them to 8 patients on thrice-weekly hemodialysis. The experience was quite long because the median follow-up was 1.5 years, and we can see that the 17 patients on maintenance on incremental hemodialysis were quite young. The group was able to demonstrate a lower pre-dialysis urea in the incremental group, which was also more stable compared to the on and off effect seen in thrice-weekly dialysis patients. So the conclusions of this group were that this approach is feasible, but in selected patients. And this approach represents a good therapeutic option when the conservative treatment alone is not longer adequate, but the patient is not yet ready for a thrice-a-week dialysis, or this frequency, hemodialysis frequency is not necessary yet. And talking about the nutritional parameters, we can see that there were no changes in body weight, total serum protein, serum albumin, transferrin, complement, and so on. So the approach was quite safe for the patients. 20 years later, the same group expanded their observations, enrolling instead of 17 patients, 38 patients on a combined dialysis diet program and compared them to 30 patients on a thrice-weekly schedule. Among the exclusion criteria, there were the presence of a pericarditis, congestive heart failure, severe fluid retention, protein energy wasting, hyperkalemia or severe metabolic acidosis, acute reduction of residual renal function, concurrent diseases, unreliable discipline with regards to dietary restrictions. As we can see, the combined diet and dialysis program group performed better in all the parameters tested, such as the urine volume output, the serum albumin, beta-2 microglobulin, and phosphorus. And importantly, there were no significant differences in mortality at the end of 2 years of observation between the incremental group and the maintenance dialysis group 3 times a week. And when the authors extended the observation to 8 years, the difference in survival became significant in favor of the incremental dialysis group. So the authors concluded once again that this approach could be useful in motivated and selected end-stage renal disease patients. About the nutritional parameters, as usual, total protein, albumin, transferrin, and complement were not different at the beginning or at the end of the observation period. In 1994, the group of the Professor Locatelli's group from Lecco performed a similar study in an integrated diet and dialysis program in which they started from 273 patients, and despite the high rate of exclusions and dropouts, were able to have complete data on 28 extensively studied patients. The GFR of these patients did not decrease significantly over 1 year of observation, and the nutritional parameters remain stable. And these patients, the fact that these patients had a quite good urinary output was testified also by a low interdialytic body weight gain between the sessions, the dialysis sessions. The patient survival was good, but the technique survival was less good because at the end of 2 months, only 1/3 of patients enrolled in the study were still on an incremental schedule. So the authors concluded this, and why this? Mostly because of compliance issues in terms of regarding the patients, because as you can see, 41 out of 69 patients initially enrolled in the study had to drop out because of poor diet compliance. So the authors concluded that once again, this approach is reserved for highly motivated patients and could become, however, an option, especially in countries where dialysis is not available without restrictions to everybody. The last experience comes from a Japanese group which published in 2018 on once-weekly hemodialysis combined with low protein and low salt dietary treatment, and showed that this approach is safe because it doesn't change the nutritional parameters and preserve the residual diuresis without affecting the mortality of the patients over a follow-up of 5 years. But once again, the Japanese concluded that the patient should be carefully selected for this approach. So if we take a global look at these trials, we can see that over the years, the protein intake has been at least a little liberalized, passing from 0.4, 0.3 grams of proteins per day to the 0.6 in 2014 and 2018, while the energy intake has remained stable over the years. The supplementation by ketoanalogues or essential amino acids is becoming progressively less necessary as the protein intake increased in the studies. So, to summarize the findings of the previous experiences, we can conclude that an incremental approach combined with a dietary regimen is safe and feasible, but only in selected and compliant and motivated patients with a relevant residual kidney function. But if we come to our days and we take a look at the last randomized clinical trial on incremental hemodialysis published last year on Kidney International, we can see that a twice-weekly dialysis schedule is safe, preserve the residual renal function, and also the nutritional parameters. But what about the diet? Nothing is said in this paper about the diet. So does it mean that we can use an incremental hemodialysis approach even without thinking about the diet? Well, in our experience, patients all start, at least, we propose an incremental start, hemodialysis start to all patients, and in our center, 2/3 of patients start dialysis at once or twice weekly. As you can see, there are no differences in survival between patients on standard hemodialysis, it is to say, a twice-weekly schedule versus other less frequent schedule. And also there were no differences, significant differences in survival if you compare patients who started an incremental hemodialysis program in our center with the patient who started dialysis always in our center, but when the incremental program was not available between 2013 and 2015. And what about the nutritional parameters? After 6 months of beginning the incremental dialysis schedule, there are no differences between patients on standard twice-weekly schedule and patients at 1 or 2 dialysis per week. The persistence in the system in our center is quite good, as at 1 year, still half of the patients are still on incremental hemodialysis, but patients are more likely to start with an incremental schedule if they have been previously followed in a specialized outpatient clinic, which takes care of advanced chronic kidney disease. In fact, the probability of starting dialysis with an incremental schedule increases of about 10-fold if patients were followed up previously in our outpatient clinic. So we tried a little to reverse the paradigm, and instead of finding all the characteristics a patient should have to start dialysis in an incremental way, we like to think about the exclusion criteria. So we should propose incremental hemodialysis to everyone, but who are the patients to whom we cannot propose incremental dialysis? Oligoanuric patients, patients with volume overload or a rapid weight gain in between the sessions, patients with high metabolic needs and so high depuration needs, patients with impaired nutritional status, uncontrolled hyperphosphatemia or secondary hyperparathyroidism, and patients who are non-adherent to medical prescriptions. But we are not full, so we always combine the incremental approach with a dietary management and monitoring. So in our center, the dietitian performs twice a year, in the absence of other clinical reasons, a dietary evaluation, and patients usually are on a 0.6 low protein diet, with supplemented or not with keto analogs according to the patient needs. But for patients who are not very compliant, who have difficulties in following the diet, we try to normalize at least the protein intake to 0.8 gram of proteins per kilogram of body weight per day. But it is important to mention that for us, non-adherence to a diet is not considered per se a contraindication to incremental dialysis start. Of course, to be able to perform this incremental program, we have more frequent controls, and we check the patient blood test every week. And we check urea, creatinine, sodium, potassium, calcium, phosphate, bicarbonate, total proteins, and albumin pre and after the dialysis session. And in the pre-dialysis phase, also, we check the complete blood cell count, the BMP, and beta-2 microglobulin. And monthly, we check the creatinine and urea clearances on a 24-hour urea collections. So we already received a couple of questions. One was high for maintenance hemodialysis or low for advanced CKD without dialysis protein intake. Well, I think that patients on maintenance hemodialysis on a thrice-weekly schedule should be on a high protein diet, 1.2 gram of proteins per kilogram of body weight per day, while patients followed with a conservative therapy should be on a low protein diet. And the other question, diuretics use or not in incremental hemodialysis with residual renal function? Yes, we use diuretics in our patients on incremental dialysis because, as we said, incremental dialysis is put on top on the conservative management when the conservative management is not enough. So we do not change, we try to maintain the residual renal function as long as possible, also, and the urinary output, also with diuretics. Another question, what are the risks of sarcopenia and malnutrition when introducing a catabolic treatment in conjunction with protein restriction? Well, this is a good question, but in order to avoid the loss of amino acids and proteins usually linked to the dialysis sessions, our patients, according to their clinical status, are allowed to a free diet the day of the dialysis session in order to compensate for the loss of amino acids and proteins into the dialysis the day of the dialysis. So to conclude, we stand on the shoulder of giants who preceded us, but I would like to pass the message that a systematic start with incremental schedules should be offered to all patients without contraindications, who do not present contraindications. That weekly monitoring for all patients on once or twice weekly schedule is mandatory, and the definition of frequency should not be based only on KT over V, only on one single parameter, but on an integrated analysis of the patient status, clinical status, biochemical profile, and no single biochemical element should lead to the change of the dialysis frequency.
Thank you so much, Massimo, for this very interesting presentation full of information. And I think we should move to the peritoneal dialysis now. So is the job of our colleagues, Carlo Garofalo. Carlo, you have to take care now of incremental peritoneal dialysis and nutrition.
Good evening. First, I want to thank the moderator and panelists. And it's also for me a real pleasure to be here. These are my disclosure. I'm going to talk about incremental peritoneal dialysis. We should start with the definition. International guidelines has recently proposed a new definition for incremental peritoneal dialysis. According to this definition, we could consider incremental peritoneal dialysis as a strategy by which less than the standard dose is prescribed, so that the combination of residual renal and peritoneal clearance is sufficient to achieve individualized clearance goals. In Western countries, a standard peritoneal dialysis prescription is typically 4 exchanges of 2 liters per day on CAPD or equivalent on APD, incorporating a long dwell. So for this reason, we should consider that incremental peritoneal dialysis can be delivered in numerous ways, including a reduction in field volumes, so lesser than 2 liters, a reduction in number of exchanges per day, also incorporating day off from dialysis, or a dry abdomen. However, this is a proposed new definition, but the studies published in the last 20 years generally adopted different criteria to define incremental peritoneal dialysis. So most common criteria is for CAPD, 1 or 2 dwells per day, and in APD, 3 or 4 sessions per week. But besides the definition, what are the potential advantages of incremental peritoneal dialysis? There are some direct outcomes, such as fewer connections, a reduced dialysate use, and reduced glucose exposure that could have a potential clinical implication, such as an improved quality of life related to the less number of exchange performed, so with a greater life participation for the patient, a reduced risk of peritonitis, but also potential reduced financial cost and environmental waste, in particular reduction in plastic waste. Also, another potential advantages could be a preservation of residual kidney function and of peritoneal membrane. Finally, we could have a reduced systemic complication of glucose because we have to remember that with full dose, the glucose absorption may constitute about 20 to 30% of daily caloric intake. On the other hand, incremental peritoneal dialysis, providing a lesser dose of dialysis, could have potential disadvantages, such as reduced small solute clearance and reduced ultrafiltration that could cause a potential poorer patient survival and increase the risk of fluid overload. Another problem is the risk of therapeutic inertia, because it could be difficult for a patient that starts with incremental peritoneal dialysis to increase the dialysis dose when the residual kidney function is reduced. But how long could we continue with incremental peritoneal dialysis? We performed in 2019 a systematic review and meta-analysis that included all the studies evaluating the outcome of incremental hemodialysis and incremental peritoneal dialysis. In particular, 7 studies included the patients treated by incremental peritoneal dialysis. And in all of these studies, incremental peritoneal dialysis was defined as in CAPD, 1 or 2 dwells per day, in APD, 3 or 4 sessions per week. In our meta-analysis, we found that the time before the increase of dialysis dose, so the time in incremental peritoneal dialysis, was 13.4 months in mean, on average. After the publication of our meta-analysis in 20 and 22, was published this narrative review that included the studies published in the last 3 years. And the authors try to compare the outcome of incremental versus full dose peritoneal dialysis. What the authors found, no difference in survival when comparing incremental versus full dose, a potential better preservation in residual kidney function in incremental peritoneal dialysis, and a similar or small reduction in risk of peritonitis. But all of these studies published till now had severe limitations. In particular, no similar criteria for the definition of incremental peritoneal dialysis was available in all the studies. The small number of patients enrolled is another limitation. Also, high heterogeneity in methods and results, and no study reported data about the conservative treatment performed by the patients before the dialysis start in terms of drugs and diet. And also no data were available on type of diet performed after the beginning of dialysis. But what is the rationale for a dietary therapy in incremental peritoneal dialysis? Diet could delay the need of standard full dose by reducing disorders in body water and mineral balances through low salt and low phosphorus diet, but also reducing uremic toxicity through low protein diet. The diet could improve quality of life, not only by postponing full dialysis therapy, but also maintaining better nutrition and reducing inflammatory stress. But what could be a nutritional approach in incremental peritoneal dialysis? So we could consider an adequate energy intake equal to 30 to 35 kilocalories per kilogram per day, a low salt diet with an intake of 5 to 6 grams per day, a low protein diet, 0.6 or 0.8 grams per kilogram per day, with or without supplementation of keto analogs, and a low phosphorus intake, 600 to 800 milligram per day. But no study till now reported the data on type of diet and nutritional intakes or nutritional status. But we could change our point of view, trying to perform an alternative option to the classical incremental peritoneal dialysis. I mean, this is an add-on of a low dose of peritoneal dialysis on the top of comprehensive conservative treatment performed by patient with CKD stage 5. This integrated conservative and peritoneal approach could be defined as a mix of comprehensive conservative care, including nephroprotective drugs such as RAS inhibitors, antihypertensive drugs including diuretics, antianemics, drugs acting on mineral bone disorder, and a low or very low protein diet associated with a low salt diet. This well-structured comprehensive conservative care is integrated with a low dose of peritoneal dialysis, defined as 1 or 2 exchanges on CAPD or 3-4 sessions per week in APD. But this integrated therapy could improve volemic and metabolic picture of patients, but from one side with the use of RAS inhibitors and low salt and low protein diet, and from the other side with the use of low dose of peritoneal dialysis, we could reduce the condition of hyperfiltration, remnant nephrons, so reducing the progressive nephrosclerosis. And finally, we could potentially delay the need of full dose, standard full dose. To test the efficacy of this integrated treatment, conservative and low dose of peritoneal dialysis, we started in 2017 a study, ICOPE-CKD, and the preliminary results of this study were presented in October 2022 in Congress of Italian Society of Nephrology. But what is ICOP-CKD study? It is a prospective controlled multicenter study with the aim to evaluate the effects of add-on therapy with a low dose of peritoneal dialysis in CKD stage 5 patients regularly followed in nephrology and with complication poorly responsive to usual conservative therapy. So patients that had the indication to start dialysis treatment. The primary endpoint of this study is the time to renal death, a composite of all-cause death or kidney failure defined as the need of full dose dialysis. So greater than or equal 3 exchanges per day in CAPD, or greater than or equal 5 sessions a week in APD, or hemodialysis start. As secondary endpoint in this study, there is also a nutritional endpoint. We evaluated a comparison at the 6 and 12-month visit versus baseline of nutritional status and intakes, in particular with measurement of serum albumin, LDL cholesterol, C-reactive protein, lymphocyte count, body weight, body mass index, and so on. These are the inclusion criteria of the studies. We enrolled adult patients with CKD stage 5, regularly followed from at least 6 months before enrollment in nephrology clinics, and with indication to renal replacement therapy start according to guidelines, specifically with complications poorly responsive to medical treatment. So this is not an early dialysis, it's on-time dialysis. At the baseline, we enrolled 222 patients from 24 centers in Italy. Patients were regularly followed in nephrology by a median time of 56 months. At baseline, the eGFR estimated by MDRD formula or measured by the mean of creatinine and urea clearance normalized by body surface area is equal to 8. The number of factors of complication unresponsive to medical treatment is equal to 3 in median, and greater than 40% of patients had more than 3 complications unresponsive to medical treatment. In particular, the most common complications were severe fatigue and malaise, refractory hypertension and related hypervolemia, and nutritional worsening, hospitalization for CKD, and alteration in mineral bone disorders refractory to the treatment, and so on. The 74% of patients at baseline followed a low protein diet. In 62% of patients, 0.6 grams per kilogram. In 35%, 0.8 grams per kilogram. Only a small part of patients followed a very low protein diet with 0.3 grams per kilogram supplemented by keto analogs. As for the nutritional intervention, it is suggested but not mandatory that patients be kept on low sodium, low protein diet for at least 3 months before baseline with this intake. At baseline, of course, the clinical picture is that typical of a patients with advanced CKD. Urinary sodium excretion is equal to 134. That corresponds to 7 to 8 grams per day of salt intake. Patients have had, of course, high blood pressure, also as specified by ambulatory blood pressure measurement with a nocturnal hypertension without physiological dipping. The number of antihypertensive drug is in median 2. 1/3 of patients took RAS inhibitors. Most common diuretics used is furosemide in 72% of patients with a median dose of 100 milligrams. Of course, patients were followed in comprehensive care, so they took antianemics drug, K-binder, drugs acting on mineral bone disorder. At the baseline, the prescription, the peritoneal dialysis prescription is CAPD. It was CAPD in 90% of patients and APD in 10%, with a similar prescription of 3 or 4 sessions per week and 1 or 2 exchanges per day in CAPD. What we saw in the follow-up. So we enrolled 222 patients.
Sorry, can we save time for discussion?
17 were lost to follow-up. 205 patients completed the study. At 36 months, we had 65 patients ongoing on treatment with integrated treatment. 15 underwent kidney transplantation. 83 patients had the need of full dose peritoneal dialysis and 20 shift to hemodialysis for technique failure. 22 patients died, but with a low rate of mortality lower than 10% at 1 year. Overall, the median time to full dose was in median 20 months, with a rate of peritonitis of 0.15 episodes per patient's year. About nutritional outcome, we did not find any change from baseline to 6 and 12 months in body weight, body mass index, serum albumin, and lymphocyte count. Also inflammatory parameters such as C-reactive protein did not change over time. The only parameter that we see a change is LDL cholesterol with a marginally significant increase over time. But crucial point is that no patients had need of full dose dialysis or shift to hemodialysis for malnutrition. So in conclusion, a new approach with comprehensive conservative care, including a low salt and low protein diet, integrated with a low dose of peritoneal dialysis, could be a reasonable alternative for patients with advanced CKD and indication to renal replacement therapy. ICOP approach delays the need of full dose dialysis for at least 20 months with a good safety. No data on nutritional status are available in study published till now in patients treated with incremental peritoneal dialysis, but our preliminary findings suggest that ICOP approach is not associated with a negative impact on nutritional status. Of course, a better quality of life and lower costs could be expected with this integrated approach. And I finished.
Thank you so much for this very fascinating presentation. And now we'll ask our eminent panelists to give some comments. Professor Chauveau, you start first.
Yes, I have a question for both of the two presentators. It's about evaluation of residual renal function, because is it only one day, 24 hours urinary output, or is it all between all the urine output between two dialysis sessions? Because we know, and in your paper, in Kidney International report, you said that it's difficult to obtain good results. And most of the paper exhibits the interest in a reduction of a decline in residual renal function. So how do you approach this problem? Because as you read in nephrology, dialysis, and transplantation from the Euclid group recently, and they say that Carlo Basile, that we have to evaluate residual kidney function for this patient.
So this gives me also the opportunity
please try to be fast as possible.
Okay, this gives me also the opportunity to answer to one of the questions that has been already posed by the attendees. So it is true that we have difficulties in collecting the 24-hour urines in our patients because some of them are old, they are not very compliant, and so whenever possible we perform the clearances once a month. Otherwise, we relied on the formula which uses beta-2 microglobulin, which was proposed in 2019 for peritoneal dialysis patients, and we do not see any reason for which it should not work also in hemodialysis patients. We are preparing also a study, technical note to compare the urea clearance to the formula which uses the beta-2 microglobulin, and we measure, and in order to doing that, along with the once monthly renal clearances, we test the beta-2 microglobulin once a month. It was my mistake in the presentation to write that we check the beta-2 microglobulin once a week. There is no need. Once a month is fine. But I would like to stress that our approach, I know that this gives a lot of targets to the panelists and to the attendees, but our approach does not rely on clearances. I mean, what we are interested in the end is the pre-dialysis status of the patient, his symptoms, and his well-being. If a patient has a reduced urea clearance, but still fares well on incremental hemodialysis, but not because it says that is well, because we see that the blood tests are okay and are sufficient to keep him on a reduced frequency dialysis schedule. We do not change the schedule according to the clearance. I don't know if I made myself clear, but if a patient arrives with
but this is a very delicate point, because yes, in your presentation there is a very important differences in the GFR for starting the methods, the incremental dialysis, because in our experience was less than 3 milliliters per minute in combined urea and creatinine clearance. In the carrier experience was 8 milliliters per minute. So it's impossible to compare these different experiences. And in any case, the amount of depuration that you are adding to the patient is paramount importance. So you should evaluate the residual renal function and add on some further clearance in order to try to counteract the reduction of the previous clearance. Otherwise, is a too empirical approach, let me say.
Yes, but we do that by monitoring patients frequently. But the other question that was posed by the attendees was, what is the average GFR at which we start the incremental program? In our paper, in the published paper, is 7 milliliters per minute, which is significantly different from the 5 milliliters per minute of patients on twice-weekly who are started on twice-weekly on a twice-weekly schedule. But now we have extended the observation, and these differences, these are not published data because we are still analyzing them, but these differences are getting closer and closer, and they start with a non-significant difference, the two approaches.
Because it's impossible to compare the survival in the different population if the starting renal function is different. Because there is a lag time that the patient didn't receive dialysis in a standard group, while of course they started earlier, and now we say that you will modify your approach.
There is the immortal bias problem.
Yes, but you, okay. Dr. Garofalo,
I think this is a crucial point. Incremental hemodialysis or peritoneal dialysis are not an early dialysis. They had to be on-time dialysis. So I think that besides eGFR level, we should start when there are complications unresponsive to all our medical treatment.
Yes, but it's true. It's true. But in any case, looking at the difference in the GFR, or estimate GFR, what do you want? There are differences between the incremental dialysis and the standard dialysis. So in some way, there is a bias of selection that is important to clarify.
Yes, but that's why I mentioned that extended and expanded the number of patients. These differences are going to get smaller and smaller, and patients now in our center start at the same GFR level.
Let me ask,
this is the approach also of
Karine, can you comment?
dialysis guidelines.
Karine, can you comment on that? Because we can see you, but we know that
Yes,
you are
sorry, I apologize, the
No,
audience,
okay.
for the
I
lack
think-
of video. Yes, so I would like to thank the two speakers for the nice presentations. I had many questions, but I think we lack time. So I would like just to ask for the nutritional care of these patients, because I think that is a key point for the safe incremental dialysis, hemo or peritoneal dialysis. I think it's the same. You talk about, Dr. Torreggiani, about the well-being of the patients, but what about the nutritional status of these patients? You measure in your experience in Le Mans, protein, albumin, but what about the evolution of the body composition and mainly the muscle mass, or and also just to finish the question, what is, before the evolution of the body composition, what is the protein intake you ask for these patients? You told us about the day of dialysis, where the protein intake is free, but what about the other days? I mean, is it the same for the patients with only one session a week? So is it 0.4 or 0.6 gram per day? And what about the evolution all along the time for these patients, when they start for one session a week and then you have to increase to go to 2 sessions a week? And then how do you monitor the protein intake in this, for this patient? I think it is the same in peritoneal dialysis. How do you move the protein intake for these patients with maybe the use of keto analogs in these specific patients? Well, this is the main question I have.
Okay, so about the first question, we monitor the body composition by performing regularly a bioimpedance about every 3 months. But it should worth mentioning that we have also a physical activity program which goes on dialysis. So we have physical therapists that that have the patients doing some exercise during the dialysis session. So this is very important to maintain also the body composition. The other thing is that patients, most of the patients arrive from our pre-dialysis clinic. So they are already on, as I showed, on a low protein diet. We do not change their protein diet, and usually is a 0.6 grams of protein per kilogram per body weight of body weight per day, supplemented or not with keto analogs according to the needs of the patient. But when I say that we try to normalize the protein intake, is because here we have a big problem of protein intake, because it is above, far above the intake which is advised even for the general population. In the general population, we know that 0.8 is the standard. Here in the deep countryside of France, we have patients whose protein intake is 1.4, 1.6. We cannot, and they eat only meat. We cannot force them to pass from 1.4 to 0.6 plus 10 pills of keto analogs per day and expect that they are compliant. and adherent to the diet. So our approach is a step-by-step approach. We try to reduce the protein intake slowly, because 0.8 is better than 1.4. Even 1 is better than 1.4. So this makes the patient adherence, especially if he sees the results. If he sees that he can stay on a reduced dialysis schedule. The last point was about how we switch patients to how we increase the dialysis schedule. Well, actually, on the basis of the biochemical profile, and we regularly monitor the dietary intake with a 5-day journal. And our dietitians are trained to analyze the 5-day journal, dietary journal that the patient brings back to the dialysis session the week after.
So, Carlo, can you comment about the questions, two questions about the uremic toxin derived from intestinal microbiota?
I had no data about peritoneal incremental peritoneal dialysis, but this is a very interesting question.
Massimo, do you have any?
Maybe I can add something.
Yes.
We do not have data on the direct measurement of peak resil sulfate or indoxyl sulfate in incremental dialysis patients. As you saw, the experience, the published experience are not many, but we have some indirect hints from studies on low protein diets. Low protein diets seem to reduce the generation of intestinal, of gut microbiota derived toxins, uremic toxins. So this is encouraging.
Okay. Philippe, do you have any further comments?
Yes, just one comment for Dr. Garofalo, excuse me.
Is a flower.
In 2009 and 2009, the Torreggiani published a study about 90 patients on with a low protein diet, with normal protein diet. It was a randomized study, normal protein diet, low protein diet, and low protein, low protein diet. And she suggests that keto acids is more efficient for the decline of renal function in these patients.
In our study, it is not a randomized study. It is an observational study. So the data about the nutritional intake is that come for previous treatment in pre-dialysis of patients. So only a small part of patients were treated by a very low protein diet supplemented by keto analogs. However, for the after the start of dialysis, we prefer to suggest only 0.6 or 0.8 gram per kilogram. So after the start, we do not have patients with a very low protein diet.
Karine, do you have the last comment?
Yes, I would just like to ask for the selection of the patients that can stay on incremental dialysis. I think that you have to select compliant patients because of the importance of the diet we have talked about, but also to the close management of these patients. Don't you think this is right? You have to look for the residual function, well-being, nutritional status of this patient very, very soon, most often than in standard dialysis. So what about the compliance of the patients, about the care, but the management we have to have with these patients?
I should summarize because we are very strict on time, saying that I understood that the Le Mans approach is very flexible, tailored to the patient. So they don't care too much about the GFR or the compliance, but try to adapt the treatment to the patient, tailoring the treatment to the patient. Is correct, Massimo?
Yes, it is, but I can, if I just can add, a compliant patient, we see him by the quantity of fluid that it takes every day. So that is just, it is already a limitation to.
I also suggest
without even
to check the creatinine excretion in order to evaluate the muscle mass, because this was, in our experience, was very important tool for early detection of malnutrition. Okay, so I'm sorry that we are strict of time, but I think the presentation and discussions was very good. So we have to thank the speakers, thanks for the group for organizing this interesting presentation, the seminar.